and welcome to the CNBC-TV18 special. And my guest today is a crusader for gender and income equality and also for improving healthcare infrastructure, not just in India, but around the world. Melinda Gates, appreciate you joining us here on CNBC-TV18, and it's good to have you on the channel. The last couple of conversations that we've had, there has been disappointment on the approach that India has taken as far as healthcare spending is concerned. Are you relatively satisfied with what's been announced in the budget this time around?
Yes, I think this current budget really recognizes the importance of health in terms of driving the economy. And particularly, I really am appreciating seeing the investments in nutrition, because that's been one place that India has been lagging behind. And I think getting the nutritional status of women and girls in particular up so that they can go on to school is really important. And the 13% increase in the budget for health overall is hugely important.
And there also seems to be a specific direction that the healthcare priority is taking. I mean, we still don't have clarity on the national health policy yet, so I'm not going to ask you about that. But the move towards insurance, and through the National Health Protection Scheme as well, we've actually seen a higher allocation there. Do you believe that the government seems to be moving the universal healthcare coverage objective via the insurance route?
Yes, I think that looks to be the intention. I met with the health ministry yesterday and looking at the finance piece of it. I think that is the intention. I think they're looking at regional models of what's working and how do you create an effective system that's a pull system and requires quality from the healthcare system. And I think that's exactly where you want to go in the economy.
You know, when we're talking about priorities, in the economic survey in its chapter on maternal health, articulates very clearly that India, in terms of priorities as far as spending on healthcare is concerned, should invest in early stage. Maternal mortality should be something that the government should be looking at very, very carefully. And that does give you higher return on investments as well. So from a policy point of view, what more would you like to see in that vision being articulated into reality?
I would like to see the maternal mortality rate actually coming down, which I think the government is looking at very, very closely. They're successfully getting women to deliver in facilities, but yet the quality of those facilities needs to come up. And then the other piece is nutrition. Telling women to immediately and exclusively breastfeed. It's the gold standard for nutrition, and making sure the community is actually working on nutrition. When you see a case of acute malnutrition, that they work on it immediately. And there are some states that are models for that, and that needs to be spread to places like UP and Bihar.
You know, in your experience, and I was just looking at the data, when we talk about neonatal mortality, and for the benefit of the viewers who are tuning in, that's the number of infants that die in the first 30 days of life. India has a very high percentage. In fact, 70% of all the infants that die in India die in the first month itself. So in your experience, given what various state governments have already done, what more needs to be done in order to bring that rate down?
Well, these facility births that are now happening, the quality needs to come up so that we're doing exactly the right thing for the neonatal birth, that time of birth. And then the nutrition piece is so important, because if you don't get your breastfeeding rate up, like Vietnam has done, you lose the child in that first 30 days. Whereas if they're immediately and exclusively breastfed and not given goat's milk, not given dirty water, you pump up their immune system and they get going. So India still has one of the highest stunting and wasting rates in the world, and yet they only have 20% of the children, of the whole child population. So those two pieces really need to be focused on.
As part of the National Food Security Act, you do actually have an allocation for pregnant women, which I think is about 6,000 rupees a month and so on and so forth, to try and, help them through that phase. We're now seeing a national rollout as far as the National Food Security Act is concerned. But, in your experience, would that work? Is that enough? What more needs to be done on that front?
Well, you need to make the system that's there more effective. So I think focusing on what we call this first 1,000 days, that is the time through pregnancy till the child is basically 2 years old. But then you've got this amazing system, the Anganwadi system, but it needs to actually be beefed up. There need to be metrics around that, which I met with the Women and Child Development Agency yesterday. They're doing. They're rolling out finally laptops so that they can actually see and have recorded, are those food rationings going to very young children? Are they going to pregnant women? And then fortifying those rations is going to be important as well.
So one, of course, is the fact that you prevent any sort of leakage as far as these schemes are concerned. But the other, in terms of being able to replicate this on scale, you've been working with state governments. What seems to be the challenge there in terms of being able to scale these schemes?
Well, you need to have really incredible technical expertise to take what's been done in other states and make sure that you're looking at data, you're using data to see whether you're actually getting the results in your health facility. You need great people working in facilities, doing the right thing at time of birth. If a woman goes into a facility, for instance, to deliver a baby, but her blood pressure is not checked right away, that's the first thing you need to do. Your chance of losing her, one of the highest things that causes maternal death, is a high blood pressure. So they need to do that. They need to clean and wash hands of the person delivering. They need to do all the right things for the baby right after they're born. It's actually not that hard, but you have to have those pieces sequenced in the right way, and the people attending the births have to know how to do that.
You know, this budget has also allocated more money towards tertiary facilities, and that seems to be a priority for this government. But do you believe that at this point in time the need really is to beef up capabilities, really as far as the primary healthcare centers are concerned?
Bill and I believe that it has to be at the primary healthcare facility level. That's where you get all the gains. That's how Sri Lanka got the gains that they got. That's the countries that we're seeing develop into middle-income economies all over the world. They beefed up the primary healthcare system because that's the first place the family goes. And
so
then,
is that where government spending should be focused on?
It does need to be spent there, yes.
And let the private sector take care of the tertiary side?
I don't know the tertiary side can all be done by private sector, but I would say
the attention of the government's money and time and bandwidth should be on the primary side.
That is our belief.
Okay. Let me then ask you, I mean, in your conversations with the government, where do things currently stand? Because there are fiscal constraints. This time around, we've already seen the government make an attempt to try and boost the spending on healthcare. It's up by about 13%. What can be done to try and encourage the private sector to perhaps partner with the government when it comes to primary health care?
Well, I think you're seeing a lot of private sector partners come in. They have expertise in terms of knowing how to do the supply chain pieces. That is a critical piece. Or how to build a data delivery system so that you actually can measure the data. So I think looking at where the private sector has expertise and bringing it alongside the government sector. The other place that we're seeing in India that other countries would love to have is a great pharmaceutical industry. You know, you've got Bharat Biotech, you've got Serum Institute. They're actually now delivering vaccines, not just for India, low cost, but the whole world. That is fantastic. And seeing the Indian government then take up those vaccines and build out a routine immunization system to get the right vaccines to children, that's what's going to get you great health.
Are you seeing enough of that?
I am starting to see it. Well, this government has made a huge investment in vaccines, and so they're rolling out pentavalent. This month, they're rolling out rotavirus for the first time, which is a diarrheal disease, and they're going to roll out a pneumonia vaccine for pneumococcus. The two biggest killers of children in this country, 600,000 children die of diarrhea and pneumonia. So when those two vaccines get rolled out and are added to the package, that's where you're going to start to see a huge number of lives saved.
So from a healthcare point of view, you know, you've been working in India through the Gates Foundation for about 13 years now. You've got a 15-year milestone coming up. Can we expect you to sort of move beyond the current states that you've been working on, or will you continue to deepen your engagement in the states that you're working with?
Well, our investments from a philanthropic point of view are always focused on where's the greatest need, where's the most poverty, where's the most inequity. And we see those primarily in the north in India. So I think you're going to see us continue to work predominantly in UP and Bihar. We do some other projects in Orissa. We do some work in Rajasthan. But again, it's very specific work, whereas in UP and Bihar, you need to get that government system working as effectively as you see in other states, and having it be that effective will mean you'll lift 300 million people out of poverty. That's the difference that can be made.
Let me now talk to you about your annual letter and what you talk about that, and the issue of time poverty. And you said that if there was a superpower that you would like, that's more time. But in your experience here in India, and you've put down some statistics there in terms of what it would actually mean to have women who don't get paid for doing all sorts of chores, whether it's outside the home or inside the home, that amounts to about $1.5 trillion as per your data. But Is it a mindset change that's really going to drive an incremental difference, or do you really need policy prescription to drive change?
You need both. So let me describe what I talk about time poverty, how I define it. It is all the unpaid labor that women do at home that we don't begin to measure it. We don't really even talk about it. In a place like India, a woman does 6 hours of labor at home and her husband does about 1 hour. Now, some of that's things she wants to do, caring for the children, caring for an elderly parent, but a lot of it is chores, washing dishes, cooking all day, carrying firewood, getting clean water. Women globally spend 125 million hours a day carrying water. So it's one of these hidden root inequities that keep women in poverty and keep them out of the labor force and reaching their potential. So economists say you can do basically 3 things about it. You can recognize the problem. You can reduce it, like with clean, safe energy, so women don't have to go collect firewood. And then you can also redistribute the work, and that's the policy pieces.
What do you think is the hardest of the 3 R's that you've just described for us?
Well, I think in some countries, recognizing there's a problem and actually speaking publicly about it is hard.
I would imagine in India, I mean, recognizing the problem and being able to talk about it is a significant challenge.
Talk about it in public and talk about it in the privacy of your home as well. So I think that's a big piece. I would say probably the redistribute may end up being the hardest, though. You have to do great policy recommendations, but also inside the home, you have to be willing to look at who's doing what and redistribute some of that load. And I think sometimes the gender inequities that exist, or what we expect women to do, are some of the hardest pieces to unroot. And it's why this isn't a problem just in India. This is a problem globally.
Yeah. You know, I want to pick up on the second R, and that is sort of the innovation piece on being able to address this problem. Are you looking at partnering with startups, whether it's in the energy space or the healthcare space, etc., specifically in India, to try and address the innovation deficiencies that we could perhaps leverage on?
Well, Bill writes about in the annual letter clean, cheap energy, which really is this second R that I talk about, the reduce. And so we're looking at, he's got a whole fund of philanthropists worldwide, some Indian, who are going to put money into a fund to look at clean, safe energy. And if you can deliver that in places in India so women aren't collecting firewood, they have more access to clean water more readily, that will make changes. So the specifics on that are yet to come, but I think some of those things will be applicable to India.